patient is a 62-year-old male who presented to the emergency department with a fever that has persisted for the past 2 days. The patient has stage 4 prostate cancer with metastases to the spine and hip. His last course of chemotherapy was completed 10 days ago with docetaxel 75 milligrams for hormone refractory disease. The past 2 days he has been running a fever of 38 degrees Celsius and taking APAP around the clock to avoid going to the emergency department. His highest recorded fever at home was 39 degrees Celsius. The patient's blood pressure was liable and required 2 liters of normal saline once in the ED to stabilize him. Past medical history is significant for the aforementioned stage 4 prostate cancer, external beam radiation, a Hickman portal cath, and a DVT that occurred 6 months ago. His family history and social history: his mother died of breast cancer, and he has no significant social history. Review systems: the patient is currently febrile and nauseous. The patient is seemingly malnourished, ill-appearing older gentleman. The patient's current temperature is 38.2 degrees Celsius. BP is 80/40. Respiratory rate 22. Weight 70 kilograms and height 6'1". He is positive for mucositis. Limited bowel sounds, erythema, and streaking are noted at the site of the Hickman port. He has febrile neutropenia, which is shown in lab values of A and C of 300, hemoglobin of 10.5. AKI, which lab values indicate BUN of 57 and serum creatinine of 6.04. His hypercalcemia, a corrected calcium level was calculated at 12.1 and phosphate was 2.2. According to discussed information, the patient is experiencing AKI and hypotension secondary to sepsis. The patient also has febrile neutropenia, hypophosphatemia secondary to hypercalcemia of malignancy. It is recommended that the patient be started on meropenem 1 gram IV every 12 hours, with the addition of vancomycin 15 milligrams per kilogram or 1 gram IV every 48 hours. Follow-up would be a daily review of his lab tests, repeat blood cultures to assess and evaluate the response and toxicities. We want to monitor our vanco by looking at our trough levels of the first dose of the trough to a target of 10 to 12 milligrams per liter, and we want to monitor liver and renal function daily. Fluids are needed, so we would continue our treatment with 300 to 500 mLs per hour until euvolemic. For febrile neutropenia, our goal is to prevent a red blood cell transfusion and reduce his temperature to less than 38 degrees Celsius. We would give him fengrastin 5 micrograms per kilogram subcutaneously. For hypercalcemia and hypophosphatemia, as stated, our corrected calcium level is 12.1. We would continue the rapid infusion of normal saline 300 to 500 mLs per hour until euvolemic, but we want to caution this in heart failure. We then have furosemide 20 to 40 milligrams IV every 12 to 24 hours. Start after adequate hydration. Pomegranate 60 to 90 milligrams IV in 1,000 milliliters of normal saline, or zoledronic acid 4 milligrams IV over 15 minutes. He has a history of DVT, so we'd like to continue the warfarin regimen, and for CHF we want to monitor the fluid intake and outtake for fluid overload.